Welcome to Chapter 13, and here we're going to be talking about psychotherapy, or more specifically, how can we apply psychology to treat psychological type of problems. What's interesting is that there are so many differences between types of psychological disorders that we need a big arsenal of strategies or techniques or therapeutic resources to be able to offer the variety of effective treatments that we need. And so we're going to be relying on a lot of the different types of psychology that we've already covered this semester. And so I think this chapter is a good way to sum a lot of the things up in terms of learning psychology, neuroscience, behaviorism, different schools of thought, humanistic psychology, and find out that, of course, as we've been talking about, one size does not fit all in terms of a diagnosis, and, as we'll find out today, a treatment. So clearly, the important thing to get from today's lecture is that we need a lot of different options for people because there are a lot of different causes for psychological disorders, and there are differences in ways that people will respond to a given treatment. And unfortunately, the one that most people think that everybody's going to respond similarly to, which is drugs, don't behave that way either. And so that means usually, currently, we're going to have some sort of combination of different therapeutic techniques to approach a given individual's psychological issues. But first, let's talk about today's interesting thing. I found it interesting that over the past decade, I've heard a lot more talk about evidence-based, quote-unquote, practices. Most often I've seen this in reference to the medical practice, and I thought it was interesting because it sounds like a good thing to do, but also, if evidence-based practice is something new, then I ask, what have we been doing for the last 50 years, 100 years? Because to me, evidence-based simply means research to support using it. And I think what's interesting is that in medicine, we often think that there's one right strategy to deal with a specific injury. And unfortunately, that's typically not the case. Of course, I'm not a medical doctor, so I don't want to speak outside of my competency. But oftentimes, based on my understanding, you're trained in medical practice as a generalist, and you tend to know that typically if someone presents with these symptoms, that leads you toward a typical diagnosis and then a familiar treatment. However, there can be a problem if many of these treatments don't have a lot of research to support them. Or not just total research, but specific kinds of research. And here we're talking about experiments, and experiments allow us to control for things like placebo effects. And of course, this also applies to psychotherapy and the field of psychology. There are a lot of quacks out there, and there are a lot of people who believe in some sort of therapy that they probably shouldn't. Modern science would view certain types of therapies, exorcisms is a classic example, as ridiculous in most cases. But the problem is, many times people think they work for reasons that have nothing to do with the actual treatment. One classic thing to think about is the variable of time. So if we're thinking about when somebody goes to the doctor, or when somebody goes to a psychologist or a counselor, many times they're going to that person, the professional, seeking treatment because they're in a state that is much worse than they normally are. Well, of course, I don't know about you, but times when I've been in a bad psychological or physical state, sometimes I go to the doctor, sometimes I don't. But either way, as more time passes, generally things get better. So one thing we need to control for is, do people simply go and receive psychotherapy, get better after a couple weeks, and how much of that is due to the actual treatment and how much of that is due to the simple passage of time? Well, evidence-based practice means in order to recommend those type of treatments, we need to have the right kind of data to show that they work. So of course we need research to show that one psychotherapy works better than another one, but also we need to know how long do the positive effects of this kind of treatment last. The longer they last, and the more positive outcome type of variables that they influence, the more likely that the treatment is doing something really meaningful. and it's less likely that it's due to placebo effect type of things. So I thought this was interesting because, in my opinion, this term has really taken off in the last decade. We do things evidence-based, and that means we're doing things better than our competitors. Well, psychology often gets a bad rap because we think there are some quacks out there, and certainly there are, but we've been doing evidence-based practice for a long time. The problem is, compared with medical science, the effects of psychological work typically aren't going to be as large. So that means you break a bone, you go to the doctor, you get a cast, and clearly there's a big effect of having that treatment done. Contrast that to depression. You feel really depressed. You're struggling in various areas of your life. You go to get psychotherapy, and you feel better, but you don't feel cured. And that's a big difference. So many people, if the therapy doesn't cure them, they may feel cheated. They may feel as if it didn't work. But the research will show that on average, it did work. It just didn't completely fix whatever you thought needed to be fixed. And so that's one thing I think, as educated consumers of research, part of getting a college education, we'll understand that there's no guarantees here, and that sometimes we're one of the 30% of people that a treatment doesn't help. Or we're also one of the 50% of treatment that it doesn't completely fix the problem, and we need to seek a combination of another treatment as well. So keep those things in mind when you're evaluating whether some of the therapeutic techniques that we're talking about are good or not good, because there's a lot of gray area in between those extremes. And as we've mentioned before, our diagnosis, our understanding, our perspectives, and most specifically for our purposes today, our treatments of psychological disorders have come a long way, baby. So compared to 100, 200 years ago, something such as schizophrenia, people are seeing things, hallucinating sensations that really aren't there. It was believed that they're overstimulated. So what you need to do is deprive them of these sensory experiences by putting them in padded suits, tying them down, and essentially making them blind as well. Now, as we know today, doing this is not going to reduce their hallucinations in schizophrenic patients. On the other hand, it's going to make them feel worse than they otherwise would. And so probably the outcomes based on a treatment you see here are going to be worse than what we do today, which is, some form of maybe cognitive therapy mixed in with some pharmaceutical techniques as well. So I think from our current cultural perspective, we can all say that this is not ideal. This is not how we should deal with psychological disorders. And fortunately, here in the US and most other westernized cultures, we don't do it this way anymore. Quick true false to get us going. As we talked about before, schizophrenia can be a very serious psychological disorder, but it doesn't affect everybody who has the diagnosis the same. And there are many people who drugs don't do anything for, but fortunately there are many people who drugs can make all the difference. They're going to have recurring schizophrenic episodes, but with the right medication and persistence in taking that medication, after the episode is passed and given the right treatment, they can go back to leading a normal life. There's also group therapy, which may have the side benefit of saving time and money, but that's not the reason why we do it. Most of the therapy we'll talk about is individual based, so a one-on-one session with a therapist and a client. But many times we need to do group therapy in addition to bring out certain dynamics and give the therapist perspectives that may not come out from just talking with one person. So of course couples therapy would be a big one. Many times somebody will be frustrated with their spouse. Talk about it with a therapist as a source of anxiety, depression perhaps, but the therapist can't truly understand who's really at fault and who needs the most behavioral change unless you see those dynamics play out in person. If you haven't noticed, I'm really trying to get rid of this misconception that these are synonymous. They are actually different. So psychotherapy is all the things that we're going to talk about today. Psychoanalysis, on the other hand, is just one specific type of psychotherapy. This is a bit of a tricky question, one of those that's almost too strange to be not true, because with bipolar we have known for over 100 years that a cheap derivative of salt, lithium, can really reduce the mood swings or the emotional swings. And of course, these aren't emotions on an hour-by-hour basis, but more emotions in terms of cycling up over the course of a week or a month, and then cycling back down. Lithium, we've known for a long time, can reduce that cycling, but also we don't have a good explanation for why it works. So that's another thing to keep in mind. Just because we have evidence that one treatment seems to work doesn't mean that we naturally know why it works. Some of them we have a pretty good idea why they work. Others, like this for example, we still don't really know, which is very interesting from a research and theoretical perspective. We'll also talk about ECT, or electroconvulsive therapy. You may be surprised to know that it is still, I won't say commonly used, so much more specifically and carefully used than it was 50 years ago, but it is still used for one very specific case, as we'll talk about major depressive disorder. If nothing else works, many times ECT or electroconvulsive therapy might be recommended. So here is our basic definition of psychotherapy. Typically it includes some sort of interaction. It doesn't have to. So there are some that may not fit this precise definition, but most will. One other thing to keep in mind, these aren't official terms that you might see in your textbook, but they're oftentimes important for a general, broad classification of some of the symptoms that a client is presenting. So, for example, neurotic symptoms are things like nervous tics, fingernail biting, maybe some difficulty with emotional regulation, but they haven't lost touch from reality. On the other hand, we have psychotic types of symptoms, and these are ones characteristic of schizophrenia, dissociative identity disorder, dissociative fugue, those types of things. And when you're showing psychotic symptoms, that is definitely something that's going to require probably different kinds and more intensive or more severe therapies than simple neurotic symptoms. And then finally we have behavioral disorders. One classic one would be simple addiction, meaning people are thinking logically, they haven't lost touch from reality, but still they're behaving in ways that are clearly detrimental to their daily functioning. And of course, only one type of these, or one type of psychotherapy, is psychoanalysis. And of all the people out there doing counseling, mental health professionals, very few of them I would suggest would be strict psychoanalysts. And finally, I think what characterizes most of the graduate training programs in the United States would be the eclectic approach. So if you're applying to different counseling programs and you're reading their sales pitch, or what do they do and what's their philosophy in training their students, many of them will say we do an eclectic approach. And that means we don't just do cognitive, we don't just do psychoanalysis, we don't just do behavior therapy, but instead we teach you the tools and the strategies and the techniques from many different kinds of therapy, so that when you're working as a professional yourself on the job, you'll be able to hopefully size up the situation and line up a technique or line up a therapeutic approach or perspective that fits best with the person who's in front of you. And that's the definition of the eclectic approach. And that's a transition from how things were done 50 years ago. There were some schools that were really strong in cognitive, and that's what they did. There were other schools that were really strong in psychoanalysis, and that's what they trained their students on. And it's not surprising that once you have those different background professionals in the real world, that can hurt the reliability not only of individual diagnosis, but also perceptions of the profession. So we've talked a lot about the psychoanalytic perspective already, so I won't spend a lot of time on it here. But it is important to talk about some basic features of Freud's psychoanalysis. And of course, Freud wrote on the interpretation of dreams, so he clearly believes that dreams are one avenue to be able to release subconsciously some of the unconscious stuff that's out there. So of course, when we're asleep and dreaming, our conscious defenses are much more relaxed and susceptible to letting things from our unconscious slip out. Again, note with psychoanalysis, it's not a one-on-one conversation that you or I would be used to, because the whole idea is for the client to relax, let down conscious defenses. That involves deep breathing, eye closing, and then in that state, it is more likely for unconscious things that are very important to slip out, and of course then the psychoanalyst is there to interpret them. One pattern that might occur in a psychoanalytic session would be the idea of transference. So what Freud found is that many of his patients, again, rich, sexually oppressed Victorian women, often said that they loved him. And that's something that is fairly common, certainly not universal, but fairly common in therapeutic sessions, where, perhaps not surprisingly, someone appreciates a trained professional listening to what they have to say, caring about what they have to say, and giving them advice, helping them out, showing them empathy. And so when somebody shows me that, I tend to like that person. It's not then a far stretch to assume that maybe I would start to have romantic feelings for that person. According to Freud, though, that happens commonly, but it does not represent real romantic feelings. Instead, it's just the idea of transference. So, if somebody in a one-on-one psychoanalytic session keeps talking about his or her parents, his or her children, his or her spouse, well, if after the course of months, maybe years, that person says to the therapist, I think I have feelings for you, the therapist is supposed to interpret that as simple transference from the emotions of the topic, that person they've talked about over this time, and just transferring those emotions to the therapist. Of course, things can take a turn for the worst in psychoanalytic sessions, and that's when we see the concept of resistance. So here is where, instead of having an open, free-flowing conversation, and again, that's not what this technique is supposed to do anyway. The idea is that you have unconscious stuff out there. It's influencing you, and you don't even know it. And so we have to, in this session, get to the root of some of that unconscious stuff. Well, of course, if your conscious defenses don't want to talk about childhood molestation or sexual problems with your spouse, you're going to have signs that signal normal people to leave you alone. So, for example, resistance could be if somebody's asking you questions about your father, and then you start stuttering, or even you lash out in anger, saying, I hate you. That's some transference, but it's also resistance. So, for example, if I'm talking with somebody and they say, shut up, I hate you, as a normal person, I say, okay, I'm going to back off, I'll leave you alone. According to Freud, though, and the psychoanalytic technique, when somebody starts showing some real anger and anxiety, that just means you're starting to scratch the surface of the good stuff. You're seeing some resistance, and unlike a normal conversation where I don't want that, in a psychoanalytic session, that's actually good. shows you're making progress. And so, of course, the joke is, in a psychoanalytic session, um, once you realize you hate your parents, then you're cured. Of course, it's a lot more deep than that. But if there is some unconscious animosity towards your parents or your children or your spouse, once that comes out, things will get better. The problem is, according to the theory, you can't get it out yourself, and you need the trained therapist to help you do it and then to interpret it for you once it comes out. And of course, I don't want to ruin this movie for you, but Shutter Island is a classic example of psychoanalytic perspective. And then there's sort of a surprise at the end, and it's unclear which way is the truth. But clearly, Leo DiCaprio has some major, deep issues, and there's a therapy designed for this character, and this character starts to show signs of resistance and other traumatic types of emotions on the way to discovering the truth. So that's one movie I do recommend if you got 2 hours and a night to kill. Now contrast the psychodynamic, psychoanalytic perspective with the humanistic perspective. So both of these involve one-on-one interactions between a patient or a client and a therapist, but here this is more like the normal conversation that you or I would have. So sort of like having a talk with one of your best friends and talking about some of the things that you're struggling with. And of course, you expect your best friend to act interested, to care about what you have to say, to sort of be able to put himself in your perspective. And essentially, this is what client-centered therapy is. Now, of course, it does involve training, so it's not just a friendly interaction. The therapist really has some specific goals, and more important, some very specific boundaries regarding the client-centered approach. But it was developed by Carl Rogers, and going back to his idea of unconditioned versus conditional positive regard, he believed that many people show symptoms of some neurotic disorders, anxiety, depression, because they simply don't have enough positive, unconditional positive regard in their life. And so if it's not in their life naturally, the therapeutic session can provide it. So again, we all have the goal of self-actualizing. Even though we're not always conscious of what our self-actualized self would look like, we want to strive to get there. And of course, we have these blockades, limitations to unconditional positive regard, manifests itself in psychological disorders, and then we feel like we're sort of stuck spinning our wheels, if you will. What the client-centered approach is supposed to do is use active listening. And what active listening does is show empathy. It puts the therapist in the client's shoes. And it may sound simple to you or me, but I think it does work for very simple reasons. When I say non-directive, for example, if somebody is talking about a problem that they're having at work, the client-centered therapist using active listening won't say, well, here's what I think you need to do. Instead, the client-centered therapist will say, okay, so it sounds like work is a problem for you now. Can you tell me more about that? Yeah, I'm having trouble with my boss. You're not getting along with your boss, are you? Yeah, my boss is a real jerk and I don't know what to do. You're searching for strategies to help with the situation. So if you're one of those people who would pay your hard-earned money and expect a therapist to tell you what to do, well then humanistic therapy is not going to be satisfactory for you. On the other hand, if you're somebody who just needs to talk things out and doesn't have somebody in their life who's willing to do that, some of this active listening, then this is a great therapeutic technique. And it does take a lot of training, and it is based in theory. Because according to Rogers and Maslow, no one can tell us what our best self would be like. No one can define for us what if we become self-actualized, what that would look like. And so by extension, in a therapeutic session, we can't tell other people what to do. We need to give them the environment in which they feel comfortable talking about this and exploring some of the things. Also, there's some sneaky research to support this. Basically, when we're free to choose what we want to do, we're much more likely to actually do those things. And of course, with neurotic disorders, if we're depressed, if we're anxious, we're still aware of how irrational some of those things are, right? So why don't we fix ourselves? Well, because we need the right environment to explore different opportunities and to really spend some time to think about what to do and what makes sense and what doesn't make sense. Client-centered therapy gives us that. Also, as we talked about before, self-esteem. I feel loved, I feel valuable. That is a key concept involved with the humanistic perspective. And what's a great point for BGSU Firelands is that we have Dr. Chris Mruck, who is a notable author and writer and theorist in the field of positive psychology. And so I think it's encouraging for me to first of all know that this is a very positive, happy, touchy-feely technique, but also that it works, and that one of my colleagues is very well respected and helping people's lives by making progress in this field. Now we're going to move on to some different therapies. Unlike client-centered therapy and psychoanalysis, which are one-on-one talking therapies, quote unquote, behavior therapy doesn't involve any talking whatsoever. And again, this goes back to the behaviorist perspective that we don't care what people think and what people feel. All we care is what things affect their behaviors. So here we're applying learning principles, and we can apply both operant conditioning and classical conditioning. So first would involve counter conditioning. And this is where we're taking classical conditioning, and many times we associate something that's bad for us with pleasure, whether it's a chemical substance, whether it's a behavior like hair pulling or fingernail biting. And instead of associating that with pleasure, we need to counter that. We need to make it the opposite, so that instead of pleasure, you associate that behavior with pain or other discomfort. So for example, if we're going to counter condition animals not to chew on the couches, dogs need to chew, cats need to scratch, so they're actually going to do those things. But if we put a nasty chemical on there, something that tastes and smells terrible to them every time they scratch it, well, that's going to counter condition that pleasure response of scratching with the aversive or gag response of something that causes us to puke. And so then cats and dogs, once you put that chemical on the couch, after that first scratch or two, they get sick, and they're going to associate being on the couch, scratching it, with sickness instead of pleasure. Moving past cats and dogs, we can easily find many examples where that would fit with our lives as humans. One would be thinking about public speaking is something that commonly creates anxiety with many people. So counter conditioning would say, okay, you know you have to give this big important speech in front of many people that you want to impress in this given conference room. And so when you think about that room, it makes you very anxious. Heart rate rises, muscle tension goes up, difficulty breathing, maybe loss of bowel functions, any number of things. So we need to counter that association. One would be, if you know the room where you have to give that speech, maybe a week before, you're going to need to spend some time in that room and associate positive things with that room. So one thing that is very easy to do is bring cookies, because everybody feels better when they smell cookies. So then you associate that conference room with cookies. You can also do some breathing exercises, maybe some stretching. So you associate that room with good things, things that inspire confidence, and gradually that anxiety should be reduced. And again, It's not a guarantee that you're not going to feel any anxiety whatsoever when you give that speech, but it will be less than if you didn't do the counter conditioning techniques. And of course, as you can see in this picture, bedwetting is something, especially if it persists into late childhood, can be counter conditioned. So for example, there can be a sensor, and when in the middle of the night that sensor detects moisture, it sets off an alarm. And of course, I don't know about you, but when I hear an alarm going off in the middle of the night, it creates a very frightened reaction, and I'm going to associate that behavior, in this case, with that aversive stimulus. What I think is interesting is, just like classical conditioning, it's very powerful, but oftentimes it doesn't work exactly like we'd like it to. So for example, we need to think about the issues of generalization versus discrimination. So for example, with this case, trying to reduce bedwetting, you're associating the experience or the behavior of wetting your bed at night with being scared. Now, if we overgeneralized, then instead of just associating that scared feeling with at night and in bed, you could overgeneralize and in essence, be pee shy. So it would be difficult to go to the bathroom in situations beyond just your bed. So given that, we need to be very careful about behavior therapy. We need to really think carefully about what kinds of situations this might overgeneralize to, or if they're going to discriminate too much between the training in the lab versus what happens at home, outside of the lab or outside of the office. So given that we talked about counter conditioning, we have two specific kinds or subtypes of counter conditioning that might be common behavior therapeutic techniques. One would be the idea of systematic desensitization. This is where we identify something that we need to fix. And again, it's just behavior therapy, so no talking, no thinking, doesn't matter how you feel. It's just, can we get your behavior to change? This is the step-by-step gradual progression. So for example, if somebody is a germaphobe, you imagine them, or you tell them to imagine shaking somebody else's hand, and they're going to be very anxious about even thinking about that. So what we need to do is find some intermediate steps between that ultimate goal. So one would be to get to the point where you can just picture somebody else's hand without freaking out. And of course, once that thing pops into your mind, you're going to have racing thoughts if you have a phobia of germs. You're going to have anxiety, but gradually that's going to subside. It may take a minute, it may take 10 minutes, it may take a half hour. But once you get to the point where that anxiety is reduced and you're still thinking about that thing that used to make you anxious, then you can move on to the next step. So of course, once we get past visualization, then we might do the rubber gloves, and it might take a couple weeks before we're comfortable with those, and then can move on into the final ultimate goal of being able to shake somebody's hand. Contrast systematic desensitization with aversive conditioning. And instead of a gradual step-by-step counter-conditioning process, aversive conditioning is drastic. Oftentimes a one-shot, very intense, very involved, and severe treatment. So if anybody has seen The Clockwork Orange, that movie basically, and book, describes a juvenile delinquent who essentially associates beating people up and abusing people sexually, if I remember correctly, with pleasure. So counter-conditioning would say, we want to change that association. And the book doesn't give him client-centered therapy by any means. They don't give him psychoanalysis. They don't care how that association started. They just want to change the behavior. And so they give him stuff that makes him puke. They force his eyes open and then force him to watch all these violent scenes. And of course, when he's in this state, he's very uncomfortable. experiencing sickness and nausea, and of course restriction of rights and the stress that goes with that. And not surprisingly, once he's let out, he wants to go back to his previous violent behaviors. But once he pictures that violence instead of pleasure, all that he can do is get sick. And so, of course, in that state, he's not psychologically healthy, right? We haven't taught him good things to do that will help him. We haven't pointed him in the right direction. We've just made him sick at doing the undesirable things that he used to do. Another classic case would be nausea, induced nausea with forced alcohol. Then your association later on is alcohol. Think about alcohol, smell alcohol, get sick. I think with some foods, we might have to do aversive conditioning. And so, has anybody seen Bizarre Foods with Andrew Zimmern? If you have, you'll know that he does eat some bizarre foods. Lots of entrails and bugs, things like that. What's interesting is if somebody is having trouble with a certain food, so for example, they eat too much ice cream and they just can't stop. Well, you could use aversive conditioning on them. So they get out the container of ice cream and then say, oh, I accidentally spilled a little bit of, or the dog did something bad in that ice cream, right? And even though they know you're just making it up, once they picture it, that could easily trigger an aversive response. And so that they think about that ice cream that they wanted so bad, then they think about the dog doing his business in it, or any other gross thing you want to come up with. Maybe a cockroach walked across it. They're not going to want to eat that. But of course, the problem is maybe they don't eat the ice cream, but they eat something else instead. So we got to be very careful about what situations really warrant strict behavior therapy. So here's classic behavior therapy with a spider phobia. So first of all, we're measuring beats per minute. This is our variable or our indicator for anxiety, for example. Of course, when we start simple, present them with a picture of a spider, they're going to have a somewhat high response to that. As time passes, eventually they pass the threshold that indicates we can move to the next step. So we move the picture closer, then we move to the toy spider, and sooner or later we can bring out the real spiders. And who knows how long this would take. Could take minutes, could take half hour, but you have to wait until the behavior changes enough that you can move on to the next step. Since we've talked about the classical conditioning aspect of behavior therapy, let's not forget about the operant conditioning side of things as well. So here is the concept of behavior modification, and just like operant conditioning, we're using rewards and punishers, reinforcers and punishers. And of course, we're not talking about how people think. Do they like this reward? How bad do they think this punishment is? We know it's a useful punishment if it changes their behavior. What's interesting, and this is sort of a side note, is Skinner was known for operant conditioning. So Skinner boxes with levers for rats to press and pellets for birds and rats to eat. Well, he also made what he called the air crib, and he thought that for babies he could come up with a good crib that provides a controlled environment. I believe it was temperature and humidity controlled, and that parents would love to have this safe place to put their kids. But unfortunately for Skinner, even though this crib had nothing to do with his thoughts on operant conditioning, he was so associated with Skinner boxes that people, consumers, assumed that there had to be electrified grids and reward pellets or food pellets systems as part of the air crib. So sort of an interesting historical side note that Skinner went to his grave talking about the benefits of operant conditioning, but he was also limited in the public perception to his operant conditioning theory. But more specifically for our purposes, how does behavior therapy work, specifically behavior modification? Well, Skinner came up with the idea of token economies. So prison is a classic example of a token economy. For good behavior, you may get TV time, you may get more time outside, you may get cigarettes, right? And so, in many times, there's no money in prisons, or at least there's not supposed to be, but there are other things that are valuable. And prison wardens or other criminal justice professionals can use those strategically to get the kind of behavior that they want. In addition, prisons can drastically differ from one to the other in terms of culture. So some prisons are really bad, meaning there are beatings, there are killings, there are rapes, and those things aren't punished. So not surprisingly, when those behaviors aren't severely punished, they're going to occur more and more often. What's interesting for us, though, is think about how we've been behavior modified. Think about a situation. Work is a classic example. What behaviors get you rewards? What behaviors get you punished? Many times, those behaviors don't look that effective from an outsider. I know in academia, many people look at professors and instructors in higher ed and think, why don't they spend more time doing this or that? Well, part of it's because we have to spend time documenting how we're performing. And we have to do other things that maybe the public doesn't see. Of course, in a perfect world, maybe we could just spend time teaching, right? And give our students the most opportunities and the most connections to the employment world that we could. But since a lot of times those behaviors aren't rewarded as much, we have to spend some of our time pursuing at least some of the behaviors that are going to get us paid. What's interesting is once you get out of that context and the reward and punishment systems change, then it can be very difficult to make the adjustment. So think about what happens to people who spent 20, 30 years in prison and then are released. Well, many times they have difficulty adjusting to non-prison society. So I think of the movie Shawshank Redemption. We think of the old librarian who was released. He had trouble in the real world, and eventually he killed himself because the things that he did in prison that were rewarded and that he felt were valued, that were part of his self-identity, were gone once he was released. Now, if you're thinking, well, I'm not planning on going to prison at any point, how does that apply to me? Well, think about what our educational system might be doing to kids. So we might reward things like reading, behaving, getting good grades. What's interesting to me, and I had to learn this myself, as a student in high school and college, I knew that if I kept getting A's, my parents would be happy, my professors and my instructors and teachers seemed happy, and all was good. So then once I got into graduate school, I kept doing those same behaviors. I made sure to study, do all my readings, made sure I was going to do great on the exams. But the problem is, once you get to grad school, everybody's smart. And so you're not going to distinguish yourself by knowing slightly more about the research than the person next to you. Instead, what you need to do is work on getting internships, making connections, doing research, making presentations or going to conferences. And all those things weren't rewarded before, so it took me a long time to realize, oh, I should be doing more of those and less of my studying and reading. So I'm not telling you not to study, but also think about the types of things you're doing now in school and whether they will be rewarded when you're working or whatever context you're going to face in the next step. So again, we can talk about our classical conditioning principles, just a bit of a review. So we give them a drug that causes nausea. It would make anybody who takes this drug, Ipecac for example, to feel very queasy and throw up. So then we take the conditioned stimulus. In fact, here it's more neutral or bad stimulus, and then give them the drug that pukes. And typically after one time, that association is learned, especially if the drug is strong enough. And so next time, this previously neutral stimulus becomes conditioned, and the thought or the smell or the taste of alcohol induces that response of nausea. So if we're comparing this treatment to either systematic desensitization and aversive conditioning, this is definitely more of the aversive conditioning. Um, and I think probably most of us wouldn't want to try severe aversive conditioning. Um, maybe a common technique would be to try systematic desensitization first. If it doesn't change the behavior, then we move on to the more severe aversive conditioning like this. Now we're going to move into cognitive therapy. And as I may have said before, my take on cognitive therapy is that it is the common sense, rational perspective. And I think for our purposes, cognitive therapy often sounds kind of obvious because when we're not anxious and we're not overly emotional, we're capable of thinking rationally. The problem is that many times we're in situations where we're not fully capable of being completely rational. And it's those times when we get into bad patterns of behavior. And then later on, we can understand that, wow, I should have done this, I should have done that. It didn't make sense for me to yell at this person. But if that's all we do, the next time we get in that situation, we have the same undesirable behavior. And here especially, uh, if you don't have a psychological disorder or don't think you have anything that you want much help with, maybe you're thinking, well, humanistic wouldn't be for me, client-centered's not for me, psychoanalysis is not for me. But with the cognitive perspective, this is stuff that is very much supported by research, and anybody, in my opinion, can benefit from cognitive therapy. And it doesn't even have to be official therapy. Here's where being a student of psychology, I think, can help us. Hopefully, we'll be able to identify some situations in our lives that we could try and come up with some cognitive techniques to help us with. We can also have a combination. We take our behavioral therapy that we previously introduced and then fold in some cognitive components. So the idea behind cognitive behavioral therapy is you're taking the best of both worlds. Lots of research supporting both behavioral techniques and cognitive. Might as well try both of them. And of course, one size doesn't fit all, but this is proving to be one of the very most efficient and inexpensive types of treatments. So a common example would be work-life balance. People know that work is causing them all this stress, but yet they continue to distance themselves from their family. They continue to have anxiety about work that in some cases can be debilitating. What the cognitive therapist would say is, what are some things you can do to reduce your anxiety? And this often involves simple things like homework. And here, cognitive therapy, there's no magic to it. Some people might think, I'm paying this person who's an expert in the field to give me insight that nobody else can give me. Well, homework lists don't work based on that. Homework lists work by simple accountability. You come up with specific things that you want to do. You make a public announcement of it. You share it with somebody else, your therapist, knowing that they're going to check up on your progress on these goals in a week or in a month. And just that knowledge that you've said I'm going to do these things, and that I know somebody is going to follow up on them, can make all the difference in keeping us accountable to actually do those things. And so, in many cases, the light bulb is within us, but cognitive therapy simply turns the light bulb on. Here we can go back to our example of behavior therapy and talk about what cognitive behavioral therapy would work like in this example. So the same procedure for the behavioral techniques, you're slowly introducing more anxiety-inducing symptoms and then waiting until a certain threshold has been crossed to move on to the next step. But here you're also having a dialogue. Okay, is this picture of a spider going to hurt you? No, I know it won't. Is that rational? No. So then why are you feeling all this anxiety? I don't know. Okay, your heart rate is starting to go down. How do you explain that? Well, I guess I'm just getting used to it. It's not that bad. And so here, we're folding in the cognitions, the thought patterns, with the behavioral benefits that are specific to systematic desensitization. And since we're talking about the cognitive perspective, it's important to refer to the cognitive revolution. So since the 60s, psychoanalysis is way down, and cognitive perspectives are way up. So there's more treatments being designed based on cognitive theory and ideas. Also, humanistic perspective, I'm sure, is way up now as well. Um, and behavioral is still quite healthy. And of course, if you combine cognitive behavioral, we're talking an even bigger slice of the pie. And again, most therapists will do the eclectic approach, meaning they don't just pick one or the other, but they may have one perspective that they use more than the others. So the dominant one, or the one that they most closely align with, for the majority of therapists out there and counselors, would be cognitive and behavioral, with a good chunk of humanistic out there too. And of course, to bring the point home, cognitive therapy tells us things that other people might find obvious. But when it's us wrapped up in this situation, it can often be very difficult to be perfectly rational, sometimes impossible. And that's why cognitive therapy, for one reason, can be very helpful. So of course, we're all going to lose a job, or most of us will lose a job at some time or other in our working lives. It just happens. Um, if we beat ourselves up over it, um, have low self-efficacy, then the psychosocial outcome that we see would be depression, and of course, then you're the sad M&M. But if you lose a job and you can maybe make a bit of an external attribution, right? I lost the job because my boss didn't see what I was actually doing, and I deserve something better. I still can be a valuable employee if I find the right situation. Then you don't see the depression. And of course, we know to think this way in many cases, but just that knowledge doesn't change our behavior. And so we need to have somebody else accountable for us to follow up. How are you thinking? How are you feeling? Where's your head now? Another classic finding of cognitive psychology would be goal setting. So instead of saying, I lost my job, I got to get a new job or I'm just going to lose my mind, cognitive therapists would say, okay, getting a new job is a very big goal. And that's the ultimate goal. We don't want to forget about that, but we need to come up with many smaller goals that will lead up to that. And so as you come up with smaller goals, build your resume, send your resume out, schedule a job interview. You have the build and self-efficacy that comes with being able to cross those things off your list. And as you make those sub-goals and keep crossing them off the list, you can clearly see your progress toward meeting your goal. And that's one thing to always keep in mind. Dream big, but don't only dream big. You need to come up with lots of intermediate goals and steps to get to your ultimate goal. You may wonder what types of titles and licenses are allowed to do therapy. We also have different programs and different silos in academia that can lead you onto a mental health professional type of career. One would be the social work, master social work. You could perhaps specialize in clinical or psychiatric. And I happen to know that currently there is a strong need for people who are qualified to work in psychiatric settings. Of course, it takes some degrees and some work and commitment, but there is a pretty good financial payout if one were to go in that field right now. There are also psychiatrists. These are a bit of a dying breed, but they're not dead yet because of one reason. Psychiatrists not only have a PhD, but they also have a medical degree. And so partly because of that, they are allowed to prescribe medication. Many times psychiatrists will get the worst cases. They'll oftentimes be affiliated with inpatient treatment facilities. If that's not something that interests you, 10 years of education, perhaps counseling would be a good path. You can get counseling degrees that lead to licensing in educational programs, psychology programs, um, even some religious affiliated programs as well. Also, you want to consider the licensure requirements for counselors can sometimes differ drastically by state. So there's a difference between Ohio and Michigan in terms of how much you have to know to be able to get your license. So that's one thing to keep in mind. And these programs can either be master's or PhD, so there's a lot of freedom there. And then finally we have the clinical psychologists. These have PhD training, and typically they do practice, maybe work some clients here and there, but they're much more involved with the research aspect. So for example, if there is a common assessment tool out there, or test, or behavioral checklist that is used in many mental health facilities, clinical psychologists probably were involved with designing that, testing it to make sure that there was data to support that it worked. And then those more on the front line, such as the social workers and the counselors, would be the ones actually using that assessment or test. So if you're interested in mental health issues and want to be a mental health professional, there are plenty of avenues to get there. Of course, if we're talking about psychotherapy, maybe we want to ignore some of the biomedical therapies, but we can't ignore them. So first is the big one, drugs. Psychopharmacology, this has been an expanding field for at least a decade or two. It's typically been a very open field, so there's been a high demand for pharmacists. There is a high demand for academics. If you're looking for a job in higher ed, if you have a background in psychopharmacology, you're probably not going to have any problem finding a job as a professor. What's interesting is there are different general classes of drugs. So you don't have to know all the different examples, but you should know what each general class involves. So for example, a mood stabilizer, this is trying to reduce some of the bipolar cycling. And one common mood stabilizer would be lithium. And again, this is one that we have known works for a long time. So it comes in a pretty simple bottle. And it's amazing that with bipolar, there's been new drugs that have come out here and there. And again, I'm not the expert on this field of psychology. But as far as I know, lithium is what's almost always used to treat bipolar if drugs are a recommended avenue for treatment. We also have the antipsychotics. This is a very strong class of medications. Thorazine is a classic example. And here you can see the old-timey newspaper ad for Thorazine. This would be in an academic journal in the 50s. Reduces the need for electroshock therapy. And so we might snicker at that a little bit now. But 50 years ago, that was no small deal because many mental health professionals had trouble ethically with doing electroshock therapy. Maybe there was nothing else you could do for the patient, but man, it sure wasn't fun to give him ECT. And so just giving him a pill is much less psychologically harmful for the professionals dealing with these patients. And of course, antipsychotics are mostly going to be in the area of schizophrenia, but we also need to watch Big Pharma because there's been some cases where they have tried to say that Thorazine would also be helpful for ADHD or bipolar. I'm not exactly sure about bipolar, but I'm pretty sure ADHD, there's been at least one pharmaceutical company that's tried to prescribe Thorazine for that. We also have anti-anxiety, if you've heard of Valium. I also believe Xanax might be an anti-anxiety. And as it sounds, anti-anxieties reduce anxious symptoms. Of course, with these, there is a strong possibility for overdose, so people need to be very careful with those. Antidepressants, here we have the classic Prozac, um, and we see the neurotransmitter that Prozac affects. So with depression, um, serotonin is obviously involved with lots of different things, behaviors and thoughts, um, but it's definitely key influence on depressive symptoms. The important thing to remember is that not everybody who's depressed is going to have a link to serotonin. And so, especially with depression, one size will not fit all. Maybe these up here a little bit more, but certainly not the case for depression. We can also see this old-timey ad for brain salt, and I just get a kick out of this every time because it says cures headaches, cures indigestion. It's also effervescent. It also um, is good for seasickness, and all sorts of other things down here. And the key is we have to be very careful about how we are consuming advertisements for chemicals or drugs. Um, we like to think that we have a lot of regulations out there to prevent pharmaceutical corporations for giving us snake oil or a placebo or something that doesn't work at all, at least scientifically. But some things are sneaking through the cracks, and so you never know when the next thing we see on TV about see your doctor or ask your doctor about this, it could be the next brain salt. So we need to know where to find answers if we're seriously considering a psychopharmacological avenue. This is a very drastic chart, and it shows the effect of antipsychotic drugs. Because, fortunately, from the 1900s all the way to the late 50s, we were increasingly recognizing that severe mental illness wouldn't just fix itself with coming to God or other classic old-timey techniques. And so, by extension, we were building facilities, we were spending money to get these people help. Sometimes just separating them from society, but also I like to think more and more help was happening here in this buildup. But we also had some barbaric treatments going on. Electroshock therapy was definitely over treated. And then once we had the introduction of antipsychotic drugs, you would take, for example, a schizophrenic patient that had made a clear break from reality and had been that way for 10, 15 years. Take these antipsychotic drugs, and all of a sudden it seems like they're more rational. They're not fixed. Most people would still identify them as something being not quite normal about them psychologically, but they were at least controllable. And so in that case, many of them were in turn released into the general population. And so this trend has continued today. In the current generation, we have many fewer psychiatric facilities, and those that we do have, people generally do not stay nearly as long as they used to. And so you can argue, one, that they're maybe not getting the treatment that they need, and also, as we're going to find out, many of them who are released in the general population are going to get inpatient treatment, but it happens in prison. And typically, I think most people would agree that the treatment you get in prison is not going to be as helpful as the treatment that you would get in a psychiatric facility. And again, we can't forget about the neurotransmitter effects. In this case, we're talking about Prozac and serotonin. So when we say Prozac is a serotonin agonist, it doesn't give you more serotonin. Instead, it blocks these reuptake nodules. So once stuff is shot out, in this case serotonin, what isn't immediately absorbed would normally be taken right back up. Now, if there's underactivity in serotonin pathways, Prozac will block some of the reuptake of the serotonin and help that to increase the absorption of serotonin. Now, of course, if we do too much, you're going to blow your stash of serotonin, and after a couple hours of feeling less depressed, then you're going to have a huge crash. So it's not just the medication, it's also hugely important regarding the dosage of the medication. Contrast this with an antipsychotic, which is a dopamine antagonist, as we talked about earlier in the semester. With schizophrenia, there's too much dopamine activity, and so the antagonist will sit here blocking some of the absorption of dopamine. And so one is Prozac would be the agonist, increases activity of serotonin pathways. Antipsychotics such as Thorazine will decrease or antagonize activity of the dopamine pathways. We also need to talk about the non-drug biomedical therapies. And as we've introduced before, electroconvulsive therapy, also known as ECT, involves sending some electrical activity through paddles into the temples. We don't really know why it works. There's usually some retrograde and anterograde memory issues. Typically that'll clear up over time. What's important to remember is that this isn't just a one-off treatment. Typically you'll have maybe once a day sessions for a week or 2 weeks, and then after that point, positive symptoms start to happen. So in the case of severe depression, this would be somebody who has major depressive disorder, has difficulty even moving, and maybe is delusional about being possessed by the devil, thinking they're dirty, thinking they smell like garbage. And maybe you try other treatments for them and nothing seems to work. Well, maybe a last-ditch effort would be the electroconvulsive therapy. And in that case, a lot of times it does help to sort of wake them up. And since you catch them at that very lowest point, it looks like it lasts pretty well. So it's not like this is something you'll have to keep coming back to do every 6 months, for example. What's interesting now is we have what's known as deep brain stimulation. And so instead of general paddles on the outside of the temples, you can insert electrodes deep into very specific areas of the brain. This is currently a very promising avenue for Parkinson's treatment, but also we're finding specific areas in the brain that deep brain stimulation might help for depression. And so hopefully I'll have a video for you. It talks about this case study showing the immediate relief of psychic pain. So depression is feeling down. Severe depression or major depressive disorder is actual pain, and the body tends to experience it similarly to physical pain. And that's sort of a revelation in understanding that difference. And deep brain stimulation appears to not make someone better, but it at least relieves that pain. So for example, if you have a hangover, you can take something to cure the headache. It doesn't solve your hangover, but it's sure a lot better than if you didn't take anything. So I think there's a lot of future involved with deep brain stimulation, which is just one more specific kind of ECT. And note this old-timey ad that I showed on a previous slide, SmithKline and French Laboratories. This is one of the GlaxoSmithKline currently, or maybe they've changed even now, but the origins of this now pharmaceutical powerhouse were built on the introduction of Thorazine. And they're still selling Thorazine today, which is a little bit sobering because you'd think in 50 years they would come up with a lot better medications. And finally, we have psychosurgery. This is where you're lesioning or destroying certain areas of the brain. The big one would be lobotomy. Now, what's interesting for our purposes is lobotomies don't happen anymore, but they used to. And it wasn't a case of hundreds of thousands of people having lobotomies. These would be cases of severe schizophrenia, for example. There's nothing else that seemed to work for them. And so, as a last-ditch effort, maybe they were uncontrollable or potentially violent or dangerous. And of course, we talked about if somebody in your family is that way, eventually you're going to experience some level of burnout. If you burn out so much more that you can't take it, and there's nothing else you can do for them, then it makes sense that in the 20s, lobotomy might have been not an ideal, but at least an acceptable route. So what's interesting, at least whenever I think about the history of lobotomy, is it was developed as an inpatient treatment. And so they would give you anesthesia, and they would go in while you were under and damage fairly specific areas of the prefrontal and frontal lobe. Now, contrast that with what happened next. Moniz, I believe is his name, took this treatment, which was expensive and time-consuming, and then made it into an outpatient treatment. So in this case, take somebody who has a severe psychological disorder, make an appointment, they come in, you lay them down, maybe a little bit of anesthesia, but very light, localized, and then you take it, and this is barbaric today, but take an ice pick-like instrument underneath the eyelids and then just sort of wave it around, severing a lot of the connections in the prefrontal and frontal lobe. And then 5-10 minutes later, a quick couple stitches to sew things up, and then that patient walks out. Now the problem is they don't walk out like they came in, right? And once you're damaging brain tissue, that's something that doesn't grow back. And as we know now, if you severely damage somebody's frontal lobe, specifically their prefrontal cortex, you're taking away a lot of what makes them human. So their ability to set goals, their ability to really control and regulate paying attention to things, that's gone. And so maybe post-lobotomy, patients were more controllable, but in some ways, it turns them into a functional zombie. You haven't damaged any of their sensory or motor area, so they can move around, they can see the world, they just can't process it and pay attention to it like a normal human could. And of course, that's very brutal. Ironically, Moniz, I believe, won a Nobel Prize for developing this outpatient technique. Thousands of patients were given the lobotomy, but clearly after a while, particularly once the introduction of antipsychotic drugs were introduced, lobotomy quickly fell out of favor. And only current science has continued to illustrate how bad a lobotomy really was. Although maybe we think that in the 60s things were a lot better, but in many cases the chemicals and the drugs were so strong and overdosed that instead of a physical lobotomy, patients were just kept chemically lobotomized. And of course, if they're in an inpatient facility, they are required to keep taking the drugs, and so they might have been chemically lobotomized for decades on end. I'd like to think that we're much past that now, but it's no guarantee. I think we're better, but I think sometimes we err too much on the side of too many drugs. And finally, we have what's known as biofeedback. Your book has introduced this a number of times, and I thought I would wait until this chapter to really talk about it. But here is where we typically think about many things that our body does as us having no control over. And in many ways we don't. But there are some specific examples, and if we have the right equipment, such as watching screens, watching what our heart is doing, or watching what given muscles are doing when we feel anxious, over time, just knowing that feedback for what our biology or what our body's doing can cause us to consciously gain control over such previously thought autonomic functions. So we knew in the 50s and 60s from Olds and Milner that you could get a rat who was immobilized, they can't move, to learn that when they increase their heart rate, they get a food pellet. And so of course it took time, but rats could, while sitting there, increase their heart rate and get that pellet. So that would be like me telling you, just sit still in your chair and make your heart beat faster. Most of us say, no, we can't do that. With the right biofeedback, we probably could. We probably wouldn't want to, but there are many types of things, especially neurotic and behavioral issues, that we would want control over. So Obviously, for sweaters, there's hope that biofeedback can help you. Um, Also with sports, this is a huge revolution in sports science. So instead of telling someone, don't take your club back so far, instead, just have something that when they reach a position that's further than they're supposed to get, it shocks them or beeps loudly, um, and very quickly they don't move, they don't make that behavior anymore. Um, so I think there's a lot of potential here in the next couple decades for treatments based on biofeedback. And of course, these require advanced imaging techniques, but as we keep getting more specific and more advanced techniques, that just increases the possibilities associated with biofeedback. A little review. Which are cognitive therapists going to focus on? If you're thinking irrational thoughts, you are correct. They're just going to say, that is irrational, you're being irrational about your love life, let's bring you back in line. Which therapy is based on the idea that we have the best strategy for us within us, we just have to get it out. That would be client-centered therapy, based on the humanistic perspective. Here we have a case of fear of the dark. So dark is associated with the behavior of fear. Well, if we want to change that association, in this case, counter condition it, we just get her to associate being in the dark with being relaxed. And a hug should be enough to induce that association. Going back to the biopsychosocial model, well, clearly biopsychosocial doesn't say that everything's just inherited. It doesn't say that the environment's the only thing that's important. Um, it's saying that, yeah, genetics and biology and family history make a difference, but we can't focus on those and ignore the psycho and social aspects, your thought patterns, and the people, the situations that you're in on a daily basis. Quick true false to wrap things up. Just thinking about your problems is not cognitive therapy. It might get close, but cognitive therapy is also specific techniques such as setting goals and making homework lists and holding people accountable. And most times people, if they're struggling with something, won't do those on their own. We may think that this is true, but this is actually false. The number is in the tens of thousands that total lobotomies, at least documented, were done. So it's a very sad time looking back on it in psychological history, but I think we tend to over-exaggerate how many people actually suffered based on this. Of course, the one size fits all. This is an illustration that doesn't work. So maybe a parent thinks that a child is bedwetting because, they were adopted and were stressed as a child. Probably not, right? There's not some psychological or unconscious reason for that. We just need to change some basic associations through perhaps behavior therapy. This is actually close to the definition of biofeedback, so this would be true. And again, holds the potential to unlock a lot of things that our body does automatically that if it's not doing them ideally, maybe we can get some control over. So hopefully, if you entered this lecture with a belief similar to this, maybe you've been convinced that this is actually false. It's not a guarantee, and the effects are often smaller than medical therapies, but it usually, research shows over and over again, helps to some extent. But building on that, we want to see some of the research. So in this case, what does research show about the population of depressed children and adolescents and what psychotherapy does for them. So here the study clearly sets out their population, but they're talking about all kinds of psychotherapy put together. So they did a meta-analysis, meaning they're trying to find all the studies that have used one or more psychotherapies for depression in this population, and trying to put all those studies together into a couple meaningful numbers. So in this case, they're talking about effect sizes, which is a statistical term, but if there's an effect size of 1, that's pretty big. So for example, it's usually about 1 standard deviation. So if maybe a teacher has a technique that increases their class's intelligence scores by 1 standard deviation, or an effect size of 1, maybe that changes the average intelligence score of that class from 100 to 115. So that's nothing to sneeze at, right? And it's looking like previous studies showed 0.99, pretty good. They argued that maybe they weren't analyzing the data exactly properly. They weren't trying to fudge it, but there were some things that maybe they should have done or maybe should not have done. And now they found that the effect size looks like more 0.33, which is not insignificant, right? But it's less than we previously thought. So now we want to break that down a little bit. It looks like cognitive treatments don't do any better than non-cognitive treatments. Here's where I say that seems to look different from a lot of the research that I've seen, so maybe I'll question this a little bit. But also I like the idea that they talked about the time effects, right? So it looks like short term, these work better than they do long term, meaning the effect size is higher for short term than this, which is probably corresponding to the long term. And that also means that we've got this confounding variable of time. And if people get better, not perfectly better, but on average substantially better, is that partly due to natural processes? They were going to get better even in the absence of psychotherapy. So how much of this effect size, if we're going to go with 0.34, is due to time, and how much of it's due to the stuff that the psychotherapy really does? Well, unfortunately, we can't untangle those things with this, which is a lot of correlational research. And so we just have to be consumers of the research and think, you know what, this is meaningful, but if I really want something, a long-term treatment, maybe I'll go differently. But if I need something right now for my son, then yeah, I'll go ahead and do this psychotherapy for depression. So, classic example of how we keep needing more and more research to answer more and more specific questions about just how well do our different types of psychotherapy work. But that's enough of my take. Looking forward to hearing your discussion of these issues and more on the discussion boards. What did you find interesting? Does something not make sense? What relates in this chapter to things that we've already talked about, or things that you've seen or dealt with in your life, or people you know, or movie characters that you've seen? So looking forward to discussing all this and more on the discussion boards this week.